Welcome back. In this third explainer of our 5-part series on the bedside vestibular exam, we are diving into two absolutely critical tools, the Bedside Head Impulse Test and the HINTS examination. We're going to show you how this incredibly simple protocol, done right at the bedside, can actually outperform an MRI in those crucial early hours of a potential stroke.
Okay, let's just get right to the heart of the matter. 35%. That is a staggering number. That's how often a potentially deadly stroke in the back of the brain is completely missed in patients who show up with what seems like simple dizziness. You see, these strokes are masters of disguise, often looking exactly like a benign inner ear problem.
And, a huge reason they're missed is that we tend to rely on the wrong tool for the job. A non-contrast CT scan, which is often the very first thing ordered, has a sensitivity of only about 16% for catching these strokes in the first day or two. It's not built to see the subtle early signs of a stroke in that part of the brain. This creates a safety net that is dangerously full of holes.
Let that sink in for a second. A normal CT scan for a patient with acute, nonstop vertigo means almost nothing. It absolutely cannot be used to rule out a stroke. And this right here, this is the critical gap in our diagnostic process. It's exactly why we need a better, more reliable tool we can use right there at the bedside.
So let's start building that better tool, starting with the first component, the Bedside Head Impulse Test, or the bHIT. Think of this as our window into the vestibulo-ocular reflex.
The VOR is just a beautiful piece of neural engineering, really. When you turn your head to the left, this reflex instantly, and I mean instantly, drives your eyes to the right, keeping your vision locked on your target. It's happening all the time without you even thinking about it, and the head impulse test is our way of directly assessing its integrity at high speed.
Now here's the key finding you're looking for. If you quickly turn a patient's head toward their affected side and their VOR is weak, their eyes are going to slip off the target along with the head turn. Then they have to make a super fast correction, a visible catch-up saccade to find the target again. When you see that, that's a positive or abnormal test, and it points directly to a problem in the inner ear. It's a peripheral issue.
But, and this is a really important but, the bedside test has a major limitation. We can only see the overt saccades, those little corrections that happen after the head has already stopped moving. Some patients, though, they develop the ability to make covert saccades, which are corrections that happen during the head movement. And these are totally invisible to the naked eye. This is a big reason why a normal-looking bedside test isn't always as reassuring as it seems.
And this brings us to one of the most important paradoxes in all of vestibular medicine. If your patient is suffering from intense, continuous vertigo, but their head impulse test looks totally normal, that is the single most alarming sign you can find. It tells you that the brain itself is generating the vertigo, all while the peripheral VOR pathway is working just fine. This points away from the ear and squarely toward a central problem in the brainstem or cerebellum.
So, how do we put all these pieces together in a way that makes sense? Well, that's where the HINTS examination comes in. It's a simple 3-part triad that acts as an incredibly powerful bedside stroke detector for any patient presenting with acute vestibular syndrome. That's that classic combo of rapid onset vertigo, nausea, and trouble walking.
This table just lays it all out so perfectly. Look at the head impulse line. The abnormal test, the one with the saccade, is actually the safe peripheral pattern. It's the normal test that's the stroke pattern. So counterintuitive, right? Then for nystagmus, a beat that only goes one way is safe. If it changes direction or is purely vertical, that's a stroke pattern. And for the test of Skew, its absence is good, its presence is bad. The most important thing here? You only need one finding in that central stroke column. Just one is a major red flag.
Okay, let's zoom in on those nystagmus red flags. If the fast beat of the nystagmus changes direction when the patient looks left versus right, that's central. If it's purely vertical, upbeat or downbeat, that is never a peripheral sign, ever. Same thing goes for a purely torsional nystagmus. And finally, if you have the patient focus on your finger and their nystagmus doesn't get better or even gets worse, that failure of fixation suppression is another huge central sign.
The last piece of the puzzle is skew deviation. All this is a vertical misalignment of the eyes, and we test for it with the alternate cover test. So as you cover one eye and then switch to the other, you're looking for any vertical correction in the eye that's being uncovered. Any reproducible vertical movement, that's a positive test, and it points to an imbalance in the brain's gravity-sensing pathways. It's a highly specific sign of a central problem.
To make this super easy to remember when you're under pressure, just use the mnemonic INFARCT. It stands for impulse normal. fast phase alternating, which is just another way to say direction-changing nystagmus. And refixation on cover test, that's our skew deviation. If you see any of these signs, you need to think infarct.
But we can actually make this test even more sensitive. So let's move on to HINTS+, which adds one more critical piece to this whole puzzle.
Okay, so imagine this scenario. You do the HINTS exam, the head impulse test is positive, the nystagmus looks peripheral, everything is pointing toward a safe inner ear issue. But then the patient tells you they also suddenly lost hearing in one ear. Now what?
This is exactly where the plus comes in. The HINTS plus exam is simply the HINTS triad plus an assessment for new acute hearing loss. The combination of acute vertigo and sudden hearing loss on one side is extremely suspicious for a stroke in the anterior inferior cerebellar artery, or ACA territory. And this type of stroke can perfectly mimic a peripheral problem, so adding this one extra check helps us catch this dangerous imposter.
All right, so we've got our findings from the exam. What do we actually do with them? This is where the test translates directly into clear, non-negotiable action.
This lays out the decision rule perfectly. It's simple and it's forceful. Step 1. Perform HINTS on any patient with that acute continuous vertigo. Step 2. Look for any single central sign. Just one is enough. And step 3. If even one of those signs is present, the next step is an urgent MRI with diffusion-weighted imaging. Not a CT scan, an MRI. End of story.
Now, why are we so confident in this rule? Because the data is just incredible. In the landmark 2009 study by Kata and his colleagues that established this protocol, the HINTS exam, when done by a trained examiner, achieved 100% sensitivity for detecting stroke. It did not miss a single one.
And let me put that into perspective for you. In that very same study, early MRI scans actually had a false negative rate of 12%. This is the practice-changing takeaway right here. In the first 24 to 48 hours, a well-performed HINTS exam is a more sensitive test for posterior fossa stroke than an MRI. Your clinical skills, your hands, and your eyes at the bedside are literally more powerful than the scanner.
So let's just boil this all down to the crucial must-remember points. First, any single central finding, any part of that infarct mnemonic, means you must get an urgent MRI. Second, never ever be falsely reassured by a normal CT scan. It is simply the wrong test for this question. And third, remember that you, the trained examiner at the bedside, possess the most sensitive tool available for catching these strokes when it matters most.
Coming up next in Video 4, we're going to get hands-on with positional testing. We'll master the Dix-Hallpike and the supine roll test for diagnosing BPPV. And, just as importantly, learn how to distinguish it from its dangerous central mimics. It's an absolutely essential skill that every single vestibular clinician must own.
Thank you so much for joining us for this critical deep dive. Mastering these skills can truly make a life-or-death difference for your patients. For more resources for both clinicians and patients, please visit us at AustralianDizzinessClinics.com. And please don't forget to subscribe to catch the rest of our series and leave a rating. It really helps your colleagues find this essential training.